I'm Srikala Shankar. In collaboration with My Startup TV, in our Leadership Talk series, we have our guest today, Dr. Srikala Jwala. Welcome, Dr. Srikala. We are delighted to have you as a guest today. Srikala, we are doing a Leadership Talk series, and you're our 10th guest this evening. We would like to understand your journey right from your college days. What made you take radiology? What made you take up MBBS, and so on and so forth? I will be delighted to ask you more questions on that. Can you please tell us your journey?
Hi, Srilata, and thank you very much for having me on your as your guest on your program. And it's indeed my pleasure. And of course, we have known each other for years now.
20 plus years now.
Yeah, 20 plus years now. So I joined MBBS in the year 1992. And before that, I started my school and my journey through classical dance together when I was 5 years old. Right. So my education and my dance went hand in hand. Sure. So much so that by the time I was 16, 17, I was a regular full Sabha performer, right? Sure. And then I came to these crossroads of, whether choose dance as my career or do medicine. In those days, I come from a service class background. My dad was an officer in Food Corporation of India. So you had a son, he had to be an engineer. And if you had a daughter, she had to be a doctor. So right. That was this typical, middle class prototype. So, I was very passionate about dance and I was pretty good at it. So, and, it's always so exciting standing on the stage and with these beautiful costumes. So I had come to the crossroads in my intermediate, and then I had to choose between being a full-time dancer or being a doctor, and also try and continue to pursue my passion, which is dance, Bharatanatyam and Kuchipudi. So my dad said that, arts are always something that give you immense happiness to your soul. So let it remain a passion and let it not be your livelihood. Choose something else as your livelihood so that you can enjoy your dance selflessly, not thinking about, whether you're able to, make money out of it, or whether, you're making a name, whether you're getting a platform or anything. You don't have to think about it. You can just dance for the sheer bliss. So I said, yeah, maybe that's right. And then I said, let me give it a try. If I didn't make it in medicine, then I told him that if I'm not getting through medicine, then dance is going to be it. So then I did my BPC in my intermediate, gave my entrance exam, got through, and luckily for me, I got admission in Hyderabad in Gandhi Medical College. And then the journey began. And then because I achieved, I completed my diploma by then. So I didn't have to work really hard on my dance because I was already a performer. So I could focus on my academics and then also pursue my dancing. And then I completed my MBBS. And throughout, I was a regular performer with my Guruji, Dr. K. Umarama. And then I got married in my internship, which was pretty early for today's times. I was just about 23, 24. And then I had to choose a specialty which kept my evenings free to pursue my dance.
Wonderful.
I didn't want to get into something which would require me to sit in a clinic in the evenings. Suppose you're a gynae or a pediatrician. There's no way that you can stay home in the evenings. You have to run a clinic to be able to do well in your chosen branch, Okay. So I said, which branch will give me a flexibility where I can work from 9 to 5, come back home and have my evenings to myself.
Why did you choose radiology? And before you answered that, while I understand, normal middle class parents, like you mentioned, is wanting a son to be an engineer, or rather an engineer and a doctor, irrespective of the gender of the children. But didn't you choose arts? Didn't you choose BCom, BSc because that would have been easier with your dance as your career, as your passion then?
Only see myself either being a doctor or a full-time dancer.
Okay. Those things were
Or
very clear, right?
yeah, it was pretty clear. And
Right.
then there've been no doctors in my family at all.
Mm,
And we
mm.
have had certain, issues where we wish there was a doctor from the family.
Sure,
And it
sure.
was always my dad's, ambition that, there should be
One.
one doctor in the family. So he said, why don't you try? If you don't
Okay,
make it, then okay, then that is destiny. Whatever is
sure.
destined is bound to happen. But why don't you give it a serious try? I said, why not?
And
Uh,
you said you cracked your MBBS exam.
I cracked
What
my
made you
MBA.
take up radiology and not? I understand pediatrician and all is a more of a full-time job, but why radiology and why not a dermatology or some other science, some other subsection of medicine?
Yeah, right. So when I was doing my internship, as a house surgeon in Gandhi, I would accompany patients to the Department of Radiology, and we wouldn't be allowed inside. I could only take the patient till there and make him sit. So I would peep in and see what they would do, and that was the time when ultrasonography had come in a big way, and CT scan
Right.
was just CT and MRI were just about coming. And
Sure.
then it always fascinated me that we could peep into the human body and see
Mm-hmm.
what's happening without having to cut it open. You know,
Ah, okay.
we
I like
could
the way you
look
said
at the
cut
body
open.
from outside,
Right.
and then see what's happening in the liver, what's happening in the kidney. And then it really fascinated me in my
Mm.
house job, because all my friends would say that I would cut out to be a good physician, because of my communication skills or thanks to dance, the way I connect with people. So they said, you have to be sitting in clinic, you are a people's person and stuff. But then it always fascinated me to be able to peep into the human body and see what's happening inside without having to do anything to the patient. That kind of fascinated me. And
Right.
then radiology was actually the specialty when I
Okay.
had my post graduation.
Okay.
So
So,
radiology
what
was
is
really coming up.
radiology? All right.
Yeah.
What is radiology? For a student who is just wanting to become a doctor or who's doing her MBBS or his MBBS first year, second year, can you please explain what is radiology? What are the various segments in radiology and how can one build a career in
Yeah.
radiology? So,
Sure.
three questions for you.
So basically, radiology is a very broad term, and it's actually an oldish term for imaging. Now it's called imagiology, because when imaging started, it started with the use of X-rays, right?
Right.
So we used X-rays and to look, take a radiograph of the chest, radiograph of the broken bones. So because it was using X-rays and radiation, it was called radiology. But as we moved forward, we started using ultrasonic waves, and we started doing ultrasound. We started using MRI, magnetic resonance, and do MRIs. So now
Mhm.
it's not just X-rays that we use, but we use so many other energy waves to image the body. So now it's actually imaging. And
Okay.
after imaging, radiology has gone further into interventions where, for somebody who's listening, you would have heard of coronary angiography. What is it? It is putting a catheter. We put a dye into the blood vessels which supply the heart. We image them real time to see where the blocks are.
Right.
Similarly, you can do that to any vessel in the body,
Mhm.
your limbs, your brain, your, upper limbs and body and everything.
Got it.
And then if there are any blocks, we can open them up with stents. If there are aneurysms, if there are balloons in the head, in the brain, we can coil them so that, they don't rupture and the patient doesn't have an emergency. And also, suppose you diagnose a tumor in the liver, you diagnose
Mhm.
a tumor in the lung. So we stick in a needle, because now we are in an era where without a biopsy, you cannot treat
Hmm.
a patient. So
Right.
it is a radiologist who stick in these needles, get those bits of tissue, submit them for pathologic analysis to get a diagnosis. So basically, we are the doctors who are going to diagnose the patient with their ailments and then give the diagnosis to the treating doctors. So they take it forward from there.
Sure.
You know, I understand there's a lot of clinical science and clinical examination, but in this time and age, because it is evidence-based medicine, everybody depends on the diagnosis made by the radiologist to treat the patients. So in a nutshell, you are the doctor who's going to tell the patient what is wrong with them and tell the treating doctor that this is what the patient has and this is probably what you got to do with them. That's number one. Number two, with interventional radiology, we are also treating a number of ailments and a number of diseases in our own way. So radiology and imaging now, it encompasses not just diagnosis, but also therapy.
Right.
Yeah.
All right. So when you're talking of the radiology and the explanation, a detailed explanation you gave, can I understand you do radiology for breast cancer? So
Yes.
a radiologist for a breast cancer specialist, can he move into something like for the limbs or for gynecology, etc.?
Yeah, absolutely. See, when I started my career, I was a general radiologist. I was not a subspecialist.
Sure.
I was a general radiologist where I was doing ultrasounds, I was reporting chest x-rays, I was reporting x-rays of every part of the body. I was doing special studies like, we do the barium studies for the gut to know what's happening in the stomach and bowel. I was doing all of that. I was doing ultrasounds of pregnant women. I was doing antenatal, we call them antenatal ultrasound. So I was doing that. I was doing regular ultrasounds. I was looking at CT scans. I was reporting MRI of the brain, spine, the shoulder joint, the prostate. I was doing everything. But as we move forward, you got to, because the medicine and each branch of medicine has grown so much in its, the vastness of subject is so much that if you remain a general radiologist for long, it doesn't take you anywhere. Number one. Number two, probably with the kind of developments in every sphere, in every organ, you're not going to be best in doing that. You will be able to report to a certain extent, but you may not be the pinnacle of knowledge and competence in every branch that, if you're handling everything, say MRI, CT, you're doing everything. It's like jack of all trades. And
Srikala, your voice is cracking.
So
your voice is cracking. You'll have to come closer.
Yeah, now it's better.
So you'll have to repeat what you just said. I can't.
So what I'm saying is, with the development of science and the vastness of knowledge that is available now, and with the advancement of the technology in imaging, there is so much about every organ that is happening, So we are in an era of subspecialization where I do radiology, and then within radiology, we have abdominal imaging, chest imaging, neuroimaging, neurointerventions, interventional radiology, and breast radiology. So it was, as I progressed for about 7 to 8 years, I was a general radiologist. Then an opportunity came in my own organization where they were looking for someone to specialize in breast. And I, being the senior female radiologist in the department, I was asked to go and, train in breast imaging and come back and develop that specialty in my hospital. And then by then I had done quite a bit of general, imaging. So I said, why not? I said, why not? Let me go train and come back and see how I do with my training and how good I am at that, And then I thought, well, I take it forward. And then there's been no looking back, thankfully.
You are associated with Krishna Institute of Medical Sciences, as we know it as KIMS. What are the various aspects that you deal with in breast cancer? What I'm talking about is there are four stages, as I know, is in breast cancer. So what is your area of work in terms of all the stages of breast cancer?
So we at KIMS, as you already know, are advocacy of early breast cancer screening and early pickup of breast cancer has been our campaign and motto right from the time that the unit was established in KIMS, right?
Right.
So what is early breast cancer and what is breast cancer screening? Early breast cancer is that when the breast cancer, the size of the cancer in the breast is less than a centimeter or a centimeter and a half. Now,
Okay.
why is it important to pick up a cancer that early? When it is 1.5 centimeters, it's barely palpable. So what I'm saying is, we want to pick up cancers even before they become palpable to the surgeon's hand or to the hand of the woman.
Right.
We always spoke about self-breast examination.
Mm-hmm.
I'm talking of something even before something is felt by self-breast examination.
Okay.
There have been a lot of randomized controlled trials done in the Europe and US, where they have found that if you pick up a cancer which is less than 1.5 centimeters, and if the cancer has not spread to the lymph nodes in the armpit, then the 5-year survival rate of this woman is more than 95%. Now, what do I mean by that? I mean, not even 5 years, the 12-year survival rates are between 95 to 98%. Means you're practically talking in terms of cure. So very rarely we use the word cure in the cancer setting. But if this is a screen detected cancer, then I can assure the patient that she is not going to succumb to this cancer.
Sure.
With confidence, So my job entails, it's two things. One is screening for breast cancer. Number two, diagnostic studies, which means that the patient has a complaint, say a lump in the breast or a nipple discharge or a simple pain, cyclical pain. Every month they have this very severe pain in the breast.
Right.
So they could come up with any complaint and then we evaluate it.
Sure.
The other limb is woman who's turned 40. I mean, she just comes to the unit to know if she's well, if everything is fine in the breast. So they just come to do a mammographic screening.
Mammographic, right.
I look at the mammogram, and then if I feel that she would benefit with an ultrasound of the breast, I add that also. If I find something, then I sit them down, counsel them that I've found something which may need further examination in terms of biopsy, where we take out small bits of tissue, send them for diagnosis, and then depending on what the diagnosis is, we tell them what is to be done next. Right? Sure. Gone are the days where women felt a lump, they go to the surgeon, nothing is done, the surgeon will remove the lump, send it for testing, and come back and say, okay, it turned out to be a cancer, so you need a second surgery. Okay. So this is now archaic. This is vintage. We do not practice that medicine any longer.
Right.
Every
I like
woman,
the way you put it.
Yeah.
So in the day and age that we live in today, like a lot of young women want to delay their marriage and also delay their childbirth. If a woman has breast cancer, can she nurse a child?
Yes, she can. I mean, depending on what kind of surgery she has chosen. Suppose it's a mastectomy, obviously she cannot, there's no breast there, but she can comfortably feed from the other breast. And depending on whether it's if she has conserved her breast, and if there is milk let down from that breast, even after radiation, because one must understand that once they choose to do a breast conserving surgery, meaning only the lump and a centimeter of tissue around the lump is removed. And it is always followed by radiation to that breast. So even after that, if there is milk production from that side of the breast, she can comfortably nurse the breast. Right. There's nothing stopping them from nursing the baby. They can very well nurse the baby.
Right. My second follow-up question to the same question is, so she's had a tumor, she's gone through a surgery, she's not yet gone through chemo or radiation. Can she nurse the child?
She can. She can. Very well. She can. There's no relation to cancer, and once the cancer is removed and she's well, she can nurse the child.
She can
And
nurse
it's
the
not
child.
like the cancer cells are going to get into the
baby.
milk, and these are all
Right.
just misconceptions that people have. But
Right.
as long as there is production, and because see, some ducts are going to get injured while the surgery is done. So if the other ducts which are intact are still producing milk, very well, she can nurse the child.
All right. I mean, I'm sure these questions may be simple for you, but I would like to answer it
Yes,
on
no,
behalf
no,
of
no.
all the audience.
These are a lot of myths and misconceptions that women have, and this adds to that fear. That fear that they have. Yeah, so it's always nice to dispel these myths. Yeah.
Doctor, you have been in radiology for many, many years now. You must have seen patients like my sister who just breeze through it. Patients who are, anxiety driven, very, very scared of even a needle. So how do you counsel them? What are the various things that a patient should understand before she even approaches you?
See, frankly, fear gets them nowhere. I have these women who feel a lump when it is probably just about 2.5 centimeters.
Right.
The fear of biopsy and the fear
The
that
needle
this
itself.
might turn out to be a cancer. Forget about the needle. The fear that, if I go and present myself to a doctor, and if this turns out to be a cancer, so they're going to remove my breast, my hair is going to fall away. So thinking of all of this, they don't even step out of their house to even get themselves examined in the first place.
Right.
For all you know, it could be an infected cyst. It could just be a fibroadenoma, a non-cancerous lump. They just sit on that. Now, unfortunately, what happens is, as you said, there are 4 stages in breast cancer. So once the cancer jumps from one stage to the other, the prognosis meaning the life that they have after treatment with cancer, the disease-free life, the recurrence-free life, or the longevity they have after cancer therapy keeps coming down.
Right.
If I say screen-detected cancer, 95 to 98% 12-year survival rate, I'm not going to talk in 90% when I'm talking about a 3-centimeter cancer. I'm not going to talk about survival rates in stage 3 or stage 4 disease. I'm not even going to talk about 12-year survival rates. We are only talking about 5-year survival rates, right? So the fear is going to get them nowhere,
Sure.
So, but unfortunately, yes, you'll be surprised. We think education equips and empowers these women. No, education has nothing to do with this. It is the way they are, the way they are made, and also
society
the
plays
family, family that they are surrounded.
Right.
The family plays an enormous role in all of this. Talking to them, convincing them, the children, you're talking about a 45, 48-year-old, probably she has a 20, 22-year-old daughter or a son. So, having that relationship where she can openly talk about what she has, and for them to pay attention, pay heed to what she's saying, bring them to a hospital. And then, it requires a lot of talking and convincing, but that's what we are here for,
Right.
So we tell them that for all it may not be anything. Just give me that half an hour of yours and we will tell you what's wrong with you,
Sure.
So, yeah, we have to convince them to do what is right for their own good. Yeah.
So, even the educated urban society women don't understand what is breast cancer or don't understand how to examine themselves. Point 1 is, what do you suggest for them? Point 2 is, what if I know it and I'm like, I'm scared of needles. I don't want to, I understand cancer means death. So I don't want to go and approach a doctor. So how do you address my two questions?
See, number one, knowing what is normal for you is very important. Normal meaning, how does your breast feel before your cycle and after your cycle? Because you must understand, breast is an extremely dynamic organ. Like, see, we understand that every time a woman menstruates, and it's a cycle of ovulation, and then 15 days later she has her period, and she knows ovaries have ovulated and the uterus lining is shedding away. But what we don't understand is, along with all of this, the breast is also undergoing its own changes, because the breast every cycle is preparing for pregnancy. The breast
Right.
is preparing itself to produce milk. Those
Sure.
hormonal
It's
estrogen,
lactating.
progesterone,
Yeah.
all these are having an effect on the breast also. So it's
Sure.
important to know what is normal for you. How does your breast feel before the period
Hmm.
and
Hmm.
after the
Hmm.
now is the era of breast cancer screening. So any woman who is over the age of 40, we advise that they go for a
Once
mammographic
we.
screening once a year until they're about 60. And after 60, we would call them biennially, once in
Mm-hmm.
2 years, right?
Got.
With or without ultrasound. That depends again on how your breast is composed. So we add an ultrasound. Now, below 40, my advice would be to do a self breast examination every month while you're taking a shower. There are umpteen number of videos on YouTube which explain to you how you have to examine your breast and know what is normal for you and what is a normal variation that happens to your breast with your menstrual cycle. Because unfortunately, under 40, if you do not have a family history of breast cancer, we do not offer mammography or any form of breast cancer screening. But having said that, in our country, more and more we are seeing women between the age of 30 and 40 coming with breast cancers. So I really can't say that, you don't have to do anything. Don't do screening, don't do self-breast examination because it is no longer scientific. We have to offer them something, after they're 30. So I believe that between 30 and 40, definitely a self-breast examination would pick up a lump, if not screen detected, at least when it is less than 2 centimeters, let's say.
Sure.
All
Sure.
right. Even then, it's a T1 tumor. It is still
Hmm.
a T1. Anything below 2 centimeters is a tumor which is stage 1. And
Right.
most likely, it has not spread to the lymph nodes.
Right.
Right.
So
So, yeah,
that
yeah.
was my question. Next question. You rightly mentioned, people within women between 30 and 40 years. Today, we find young women, late 20s or early 30s, having breast cancer. What are the reasons? Is it just
See,
lifestyle or is it food?
I strongly believe if you take out the genetic predisposition, okay, there is a subset, about 10% of cancers are genetic. One must understand that if you have a family history of breast cancer or ovarian cancer, you may be predisposed to have a breast or an ovarian cancer, or rarely a colonic cancer. All right. So family history meaning grandmother on
Hmm?
both sides, paternal, maternal, aunts, maternal aunts, paternal aunts, and your own mother and sisters. So this forms the family history of breast cancer. Right now, if we take out that subset of people who have family history of breast cancer, the rest are all these sporadic cases of breast cancer for whom we really don't have an explanation in this time as I speak. But we surmise that it has got to do with it's either from the air, the Panchabhuta, as I would say. I always say, what is body made of? After all, it's made of these 5 elements. It's the air, the water, the food. Indirectly, the food comes from the soil. So it
Hmm.
has to come from any one of these. And
Again,
of course,
the soil is filled with chemicals and what
chemicals,
pesticides,
absolutely,
etc.
pesticides. So plastics, are being blamed in a very big way for many, many cancers. especially the female cancers,
Right.
because these are all estrogen dependent, and there's a theory that these plastic molecules mimic estrogen, and the body senses it as exogenous estrogen and reacts to it as if it would react to it.
If my family member, my sister, my mother, my maternal cousins, maternal grandparents, grandmother specifically, have cancer, am I a high risk patient?
Certainly, certainly. So, how we stratify risk is that we look at first degree and second degree relatives. First degree meaning mother and sister, your immediate blood relations, your mom and your sisters, older or younger sisters. And second degree would be your mom's sister or your grandmother. Third degree would be your cousins, your aunt's daughter, or your masi's daughter, your bua's daughter. That would be third degree. So we say that if you have a single first degree relative who was diagnosed with breast cancer under the age of 40, then you're straight away a high risk.
Sure.
Then if you have two second degree relatives under the age of 50, then you're a high risk.
Okay.
Now, you can ask me, so what? Why is this important?
Right.
This is important because I'm not going to be recommending you the same set of tests in the same interval as I would recommend to a person in the general population. Because when we say high risk, the chance of this person getting a breast cancer is close to 20 to 25%. Lifetime risk is 20 to 25%. And when we say average risk, we are talking about 10 to 12%.
Okay.
So you carry a double or twice the risk of breast cancer than the general population. So the kind of tests I'm going to do on you are going to be different. And the time intervals are also going to be much shorter. Right?
What do you mean by time intervals being shorter?
See, for the general population, as I said, some countries recommend breast cancer screening once in a year after the age of 40. Some countries recommend once in 2 years, and some others recommend once in 3 years. Depending on which country you live. But unfortunately, in India, we do not have population-based breast cancer screening programs, because the scientific explanation for that is that breast cancer incidence has not attained such proportions that it can be added in a regular screening program.
Okay.
Right? So, but then, as doctors and specialists, we see so much happening around us that we don't think we are very far away from that day when, breast cancer is going to take, is going to take epidemic proportions, right? So yeah, that is scary. That is scary, really, believe me. So as on today, what we recommend is an annual mammogram for the general population, an annual mammogram starting the age of 40, at least till 60, and then you can come once in 2 years. Okay. But if you qualify as a high risk for breast cancer, then the recommendations as we speak today are that I see you every 6 months.
Got it.
So I do a mammogram and an MRI of the breast at 6 monthly intervals.
Okay.
Right? So I'm seeing you every 6 months. So if you see me in January, for example, I do a mammogram. Right. And then I bring you back in July for an MRI of the breast.
Okay.
And then take you, do a mammogram in the following January. So I see you every 6 months so that I do not miss cancer that has started, assuming that, today you're well and tomorrow something is started. 6 months is not too far away to get a control on the disease. Okay. So that's where we are today.
What is the difference between ultrasound, MRI, and CT scan?
Okay. Ultrasound is where we use the sound waves. Technically, we use the ultrasonic waves in the frequency of about 3.5 to 15 megahertz, depending on which organ you're interrogating or which organ we are examining. All right. So in ultrasound, we have a transducer, a probe. You must have gone through that ultrasound, right? There is this funny little thing that we rub on
like
the
a mouse
with a gel. Yeah, very, very similar to a mouse. So that emanates ultrasonic waves which hit the organ and then get reflected. So for abdomen and deeper structures, we use higher frequency, obviously, because frequency is indirectly proportional to penetration. So if we want more penetration, we want lesser frequency.
Right.
Now, if I'm examining your thyroid gland, or I'm doing an ultrasound for, these IT guys have this carpal tunnel all the time, So
Me here.
I know, that's why I'm saying that. So you guys are on the laptops and mouse. So if I have to see what's happening in your carpal tunnel, then I don't want too much penetration, right? So I'm going to use high frequency for superficial structures and lower frequency for deeper structures.
Okay.
So
in fact, I have a carpal tunnel syndrome.
So you need an ultrasound. So ultrasound is no radiation. So as I said, we use ultrasound, ultrasonic waves, which do not carry any radiation hazard with that. So we can perform them. It's more easily available. Of course, it is operator dependent because it depends on how much knowledge I have, how much competence I have in interpreting what I'm seeing on my monitor. Right? And then whether I have actually looked at that organ that carefully or not. It is not automatic. It is operator dependent. It depends on the skill of the person who is performing. Now, the next is CT scan. CT scan is again an X-ray based investigation. We used X-rays to do our chest X-ray, a simple X-ray, or a broken bone or a back, a painful back, you do an X-ray or radiograph. So we use the same X-rays, but here what we do is we take cross-section of the abdomen or the brain, we slice it slice by slice and get sections of the body and we interpret those images. So these are all black and white and shades of gray.
Sure. When you what Srikala mentioned was slice is not cutting slices into like beans or bendi, but slicing in terms of the imaging.
Images. I'm getting a slice by slice image of the organs in the body, right from the skin to skin. So I'm able to see the liver. It depends on how much thickness I have in my setting. Depending on the indications, it's too technical, but that is what we do. We get a slice by slice image of the chest, the abdomen, the brain, the legs, the thighs, the pelvis, all of that. But this involves radiation. So, CT scan became extremely, a household discussion thanks to COVID. Everybody knows CT chest, that is the investigation to diagnose COVID. So we all got a lot of radiation thanks to COVID. But yes, if there is one investigation that one has to be really wary about in terms of radiation dose, it is CT scan.
All right. Can a lady get breast cancer post-menopause?
Absolutely. Absolutely. Breast cancer, if we are not talking about the young cancers, is a disease of the peri and postmenopausal women. Theoretically, I would say, because I've seen so many young now, I don't want to scare people who are watching me, but then, yes, we are looking at a different disease. The disease is evolving into a different one now, but historically and in general population, it is a disease of the peri and the postmenopausal women.
Menopause, yeah. What Srikala is definitely not scaring, but more educative to the audience, to the young audience out there. Young professionals, both students and young professionals who are not aware of breast cancer. She's just explaining in detail and not scaring anybody.
Yeah. Awareness and knowledge is power.
Absolutely.
No matter what your age, you could be 22, 25, 28, 30, 30.
Or even 58.
Anything, you're a woman, you have breasts, you're at risk.
Right.
So anytime you feel something different, it's always wise to go
Please go to a doctor.
examined, get evaluated. That's all that I'm saying.
Sure. As a radiologist, as a doctor, what are the 3 very exciting things that you have faced in your career? And what are 3 challenges that you have faced?
3 exciting is...
Exciting, or, that adrenaline jump.
When you're doing your post-graduation and you're training in radiology, of course, in your house job, you do deliver babies in the labor room posting, and you see the babies, the newborn babies. I mean, it's amazing to, as a 23-year-old to hold newborn which you have delivered in the labor room. I mean, that's amazing. But to add to that, I ended up doing radiology where I tell the woman that she's pregnant, and I see the baby from the time it was conceived to probably a day before it is delivered. And there are times when I've seen the baby, I've scanned the baby a day after it's delivered. So I've seen the entire journey from the time that it was conceived, and it's looking at you in flesh and blood. The baby is staring at you. I mean, I cannot explain that, that feeling that it gives me. It's extremely, very gratifying, and you feel so blessed. You feel so blessed.
But as radiologist, what are the 3 exciting things that you went through?
Yeah, so when I tell a woman, somebody longing to have a baby, and I tell them that you're pregnant, I see the joy in their face, and when they deliver the baby, they come to you and say, "Doctor, this is my baby." Oh, that makes me amazed,
True.
And the other one was when I first diagnosed the first screen detected breast cancer. I remember the lady's name. I cannot reveal for the reasons of anonymity. She was a 50-year-old unmarried lady who was staying with her brother and was working for the national, the NFC. So as a part of our screening, when we started off, we had this bus which was going to all these organizations, a mobile van where we were getting women to do breast cancer screening. So she was 50-year-old and she came, and I read her mammograms a couple of days after it was done. And I picked up this little 5 millimeter area of distortion. So we sent a message to the NFC saying such and such woman who came for her screening needs an additional test. So she came to us. She stays with her brother and family. And I did the biopsy. Okay. And imagine doing a biopsy of a 4 millimeter tumor. It's as good as it can get, and tough. That was my first case after my training, and the gap of size. It's really tiny. And there was a gap of 6 months between my training and me starting to do breast cancer screening. So I was not sure of my skills, and I did get the right tissue. And my pathologist called me and said, "See, you must understand that unless I pick this up and I biopsy it, my pathologist is not going to get a chance to see such a small early cancer."
Got it.
We are as good as what we see and we get as a clinical material. So my pathologist called and said, "Jwala, I have not seen a cancer as early as this in ages." So she confirmed that it was an early cancer. This was in 2007, December. And believe me, she was in my office 4 months ago, about 6 months ago. And she's doing absolutely fine. She's now 2007 to 2023, 16 years. She's 66, 67-year-old, absolutely fine. And Wonderful. Then more, God has given me this opportunity to save a life. I'm so fortunate that, I have this opportunity to make a difference in a woman's life. Sure. It's absolutely thrilling. And
what
number
3 challenges you had?
Sorry?
What are the challenges you went through?
Challenges are difficult patients, Are, the minute you say, I see something, they just break down, and it's so difficult for them to. It's a shock.
Process.
Somebody just walks in thinking, she knows everything is going well in her life. She has a beautiful family. Children are doing well. Husband is extremely supportive. She just walks into the clinic, assuming everything is fine. And here I am telling her across the table, the dear lady, this is wrong with you. This is a cancer, unfortunately. Believe me, it's not easy.
True.
It's not easy because I'm a woman. I have a family. I have a young family, and you know how important a woman is to the household. Everything revolves around.
Yeah, she's
the
because
she holds everything together, and to see them crumble and just be devastated in front of you is not easy at all. It is extremely challenging. No matter how many hundreds or thousands of women I would have spoken to, every day it is different. And for me, she is an N number, but for her, it's only me. And
for you also, she's a new case. She's a new person to deal with and emotions to deal with.
Some people say, doctor, oh yeah, you see so many every day. For you, it's nothing. No, it's not like that. It's not like that, because I understand that I'm the only one for her. For me, she may be the fifth case of the day, but I understand that I'm the only one for her as on that day in that moment. So I have to keep giving myself this, this morale, the boost. We also crumble. We also feel bad. I have to break this news to a 32-year-old lady with 2 little children. I mean, to tell her that she has a cancer, and believe me, young cancers don't do well. I know everything, but then I have to put up this brave face, and I have to be that pillar of support in that moment to her. I cannot be emotional. I cannot be sympathetic. I have to be extremely stoic, put this across to her, but at the same time be empathetic to her.
Very true.
All that support.
Yeah, very well mentioned that you said empathy, because you cannot be rude, you cannot be stern, you cannot get angry. These are some elements which I think a doctor plays a vital role in dealing with emotions for her own self and for the patients. You're not only dealing with patients, you're dealing with patients' family, and they can get hyper, they can get angry. So how do you deal with the patient's family? More than anger and angst or depression, they get very hyper. So
you have to just calm them down, keep talking, and then that is what that is where all the other things that we do, that we need to do as doctors come in. Even as doctors, because I don't know if I can say this, but this is a lot of negativity. If you're telling her when she has a cancer, she's sobbing, she's crying, the husband breaks down, the children are devastated. So it's not just the patient. When it's cancer, it is the entire family. So you are breaking the bad news. So for me to gather that composure, that strength, I have to train myself to do that. I have to work on myself. Each one of us has a coping mechanism. For someone, it may be meditation. For someone, it can be fitness, running. For someone, it could be nature walks. For someone, it could be music. But we need to look at something beyond the physical to be able to gather that kind of balance and composure, to be able to handle these patients at the same way at 9 a.m. in the morning to 4 o'clock in the evening. You must remember that as doctors, we are human. We also have a family to go back to. I cannot allow this to affect my balance of mind when I come back to a family which is waiting to, share their day, how their day unfolded. So I got to have that patience, not just with my patients, but also with family. So for me personally, It is music and meditation, which I believe gives me that strength and the love of the work that I have. I just love what I do. I just love what I do, and I believe this is the purpose of my life. I keep reminding it. Yes, we have our good days, we have our bad days, we have very difficult patients, but then we just got to sit down, calm down, give ourselves that 10 to 15 minutes, take a deep breath, go back.
Go back and attack the next day, right?
Yeah.
Like Dr. Srikala just mentioned, it is what is very, very visible in her talk as she's not just a doctor who likes her job, it's the passion that drives her. It's very visible on her face and eyes. That's passion is what drives her every day, irrespective of the disease that she's going through, or she's treating patients. I'm sorry, I'm not going through, but treating patients and their families that they deal with. It is the passion, like she very rightly said, she deals with a zillion amounts of emotions of her own self, dealing with patients, dealing with families, because it's not easy to tell a patient who's just walked into her clinic saying, hey, you got cancer. And nobody in cancer today, till date, despite technology advancement, is still a very forbidden word. Srikala, lovely talking to you. My next question to you is, what do you suggest, advise the young medical students who want to take up medicine, become doctors, not necessarily radiology, but become doctors as neuroscience, gynecology, etc. What is the advice that you would give young doctors?
As I said, and as you said, passion is the key word. And you must remember, you should not, studying medicine entails studying for at least 6 to 9 years. 6 plus 3 plus 3. About 9 to 12 years before you come out as a specialist or a subspecialist, at least 12 years. So you're giving 12 years of your prime life to this subject. So obviously I need not say that the kind of passion you should have, that, it has to be immense, and then you should be willing to work hard. And you have to have compassion, because here these are people. These are people in flesh and blood. These are not computers. These are not brick and mortar. These are not wires, right? These are not cash. These are not papers. These are people in flesh and blood with emotions, sentiments, and you cannot deal with them as a job,
Also, you cannot deal with the same with different patients in the same manner.
The same way,
You'll have to deal with the Srikala differently. You'll have to deal with
Absolutely, there is no just one right way. There's a certain way I would talk to somebody. I can't repeat the same thing to another lady because she speaks to me from a different plane. So I got to get myself to her plane and then talk to her in frequency that would match her, the kind of person that she is. And then all this comes provided you have the passion for it. Identify what you like. Remember, this is what you're going to practice for the rest of your life. So you better like what you're doing. Don't do it because it is fashionable to be a doctor, or there's family pressure, or you think you can earn a lot of money. Believe me, if you think there is a lot of money in medicine, I'm sorry, no. There's not a lot of money in medicine. There are 100 better ways of making money, and much earlier than you would make money in medicine, because by the time you just qualify and come out, you're going to be 28, 30. And then that's when you have just started. And you look at your engineering colleagues who are, who have a 5-digit annual salary, they're going to be in depression, So this is not a profession that you should come for if money is your aim. There are 100 better ways of 100 different ways of making money. Yes, you will make money also, but primarily understand that you're investing 12 years of your life. So you got to love it and enjoy it and have a passion for this and have a love for humanity.
Hmm.
We should
Money
love
is
people.
not just the factor. Money is one of the probably
Money
the
is one of
factors.
the things. Money
Yeah.
will come. Money will come. You know, medicine as a career assures you of a decent living. It
True.
doesn't assure you richness.
Luxury. Yeah.
Understand? Luxury. You will have a good life. You will have a lot of respect in the society. You are, as doctors, when everybody knows that we do derive, but then that comes with a lot of hard work, passion, and commitment to
And compassion, like you rightly said.
compassion. You can't do it like any other job.
Right. And for all the weak hearts or be it the girls or boys who run away from medicine, please run away from injections. Please don't take medicine. Yeah. Last couple of questions. How do you manage to have work-life balance? You also mentioned, and I know you personally, that you are a classical Kuchipudi dancer. My first question to you is, do you still continue to perform? Second is, how do you manage to have a work-life balance? Work-life balance, not just work and home, but work and a second career in terms of Kuchipudi dance.
Yeah. So luckily for me, as I said, by the time I came to my 12th standard, I was, I was a pretty decent performer. So, I was through my basics and I was performing regularly. So through my medicine, I continued my art. I never bunked my dance classes, citing difficult, exams and stuff like that. I know my mother, I should thank my mother for that because, it might sound very cliched, but time management is the key.
Okay.
Live, I tell my children also that this moment, as I'm talking to you, I look at it this way. This is time away from home, from family, from dance, from my work, right? So the value that I attach to this moment in my hand is all that I'm depriving myself, which I enjoy much, much more. So when I think of it that way, this moment becomes extremely valuable to me. Right. And I give my 150% to this moment in hand. This is something that my mother drove into my head, that the moment in hand, once gone, is gone forever. So make the best of it. I mean, you'll be surprised. I performed through my board exams in my 10th. There was this gap of 3-4 days between exams. And I had this very prestigious performance where I think R. Venkatraman was the president of India. And I was playing a very key role in a ballet, which my guru had choreographed. And she wanted me to perform. In between my exams was the day of the performance.
Sure.
She told my mother, and she said, why are you even asking me about that? You should just go dance and come. What were you doing the entire year if you cannot pass an exam, if you didn't study one day before the examination? That's so sad. And I was like, okay. I went ahead and performed. So it does take, but then, if you love doing what you're doing, you wouldn't do it any other way.
Absolutely.
Simply.
Do you still perform?
Yes, I do. Not like like your sister, but then yes, at least 5 to 6 shows a year. And I try and teach a few students in the weekends because I took over as a director of my dance teachers academy after she left. So I have a few students. So I run a dance school. So I take dance classes twice a week. And I keep it alive because that's where I completely unwind,
Absolutely.
That's
spoken like my sister has. I completely resonate with what Srikala mentioned. I come from a family of art. My sisters have been are Bharatanatyam dancers. Sorry, I repeat. Varshini, you'll have to edit that. So my sisters are Bharatanatyam artists, a very well-known, renowned artist, and Ananda Shankar, has had her corporate as IRTS officer and a dancer, and she's managed both simultaneously. In my own way, I am a HR professional and do podcasts, write poetry, etc. So the context of not having time doesn't come into the picture at all. Yes, like she rightly said, you'll have to manage time, you have to allocate time, and you can do 10,000 things at the same time. My last question to you, or second last question to you, is what do you wish to do in future as a doctor and in terms of your Kuchipudi career? I would like to believe it's a career.
I would, I do a lot of diagnostic work, but in the next phase of my career, I would like to do more work on the field. Reach out to these women at the taluk level, at the village level, maybe, train people to go and, teach them the importance of breast cancer screening or self-breast examination in case they don't have access for mammography. Try and see if we can kind of, try and get a mobile van for breast cancer screening in the, underprivileged women in the villages and in and around Hyderabad to start with. So I want to take the next phase of my career into, to be more socially relevant, not just sit in the hospital. Of course, that is always there, but because that's where you are actually looking at patients with breast cancer, diagnosing them, that is also important. And
but you want to reach out to more people.
Advocate, take the breast cancer screening advocacy forward, give a thrust to this campaign, educate women, both rural and urban. I don't believe urban women are any wiser. They are as foolish. I'm sorry, but I know because I've seen them. You sometimes wonder, they're so educated and how dumb can they be, when it comes to their health, their body. You'll be surprised, how dumb they can be sometimes. Probably, stemming from a deep fear inside them, probably. That's what I think, and just forgive them for that. But then try and educate the young women, because, if I'm talking to a 22, 23-year-old, I'm educating her. At the same time, she is going home and looking after her mother, her sister, her grandmother. So I want to empower these young girls, especially in corporate offices, in IT offices. We do that, during the Women's Day celebrations and Women's Day month,
more often.
Breast Cancer Awareness Month. So I want to reach out to these young girls, educate them about breast cancer, and then also educate them that cancer now is not synonymous to death. There's so much happening in cancer therapy that you don't have to think of succumbing to the disease. There's so much we can do. Yes, do go through a bit of pain and a little bit of, you have to attain that. But then after that year or two, you're completely well. You have an entire life ahead of you.
Absolutely.
So cancer now is not synonymous to death any longer. So one has to get that myth out of their head. So I want to work more in the public and, have more work relevant, socially. So that's where I see myself going in terms of being a doctor, and especially, how breast imaging happened to me is a story by itself. So I believe I'm here with a purpose. So I think that's where I think I should be going, and then He'll take me there. And then as regards to Kuchipudi, I'm teaching now, and then I'd like to probably, train students academically, maybe, prepare them for examinations, prepare them to take Kuchipudi as a career path. train them academically in Kuchipudi, maybe for a BA or an MA dance and PhD in dance, events that kind of interest in them to take up art as a career. If I can manage that. And then, of course, in breast imaging too, I want to train more and more radiologists in breast radiology, because among all subspecialties in radiology, breast imaging is quite nascent, quite young, and not many radiologists understand the importance and its potential for the future. So I want to train more and more women radiologists or men, male radiologists who want to take up breast imaging.
Sure.
I want to train more of them and bring them into this society for the greater good of women in this country.
I think from my end, I would love to introduce you and invite you to various corporate organizations where you can come and educate the young women, both men and women, because men can also go and educate their mother, sister, brother, whatever, mother, sister, grandmother.
Grandmother,
Very important. I will.
Spouse.
Yeah, I will definitely take it up and introduce you to various corporate organizations. Depending on your time, I would love to have you come and address them. If I don't do it, please ping me and say, hey, please introduce me. I would love to do it. So it was wonderful talking to you, Srikala. Thank you so much for being our guest today. You have really opened up many areas where people are kind of having a negative image on breast cancer, the seriousness or the disease per se. And I think you have also opened up the fact that it can be very, very positive. So thank you so much. It was wonderful talking to you. Thank you so much.
Yeah, my pleasure. Thank you so much for having me on your show. Thank you.
Srikala, can you please let us know what are the various awards that you won in your entire career so far?
Yeah, so I'm a recipient of Annamacharya Scholarship. And then I have been an invited performer at the Khajuraho Dance Festival. And I've had a title of Nritya Chudamani from Pushpagiri Swamiji from the Mutt.
And your awards as a doctor?
Doctor, my paper was adjudged the best paper in our national conference as a postgraduate. And then I've presented a lot of scientific work in our prestigious, our national journal, which is the Indian Journal of Radiology and Imaging. And then I'm a very avid speaker in a lot of our CMEs, the continuing medical education. And then I've held a very high position in our breast imaging society. And some of my papers and my work have won gold medals. So, wow. Yeah.
Srikala, it was wonderful talking to you. You have explained in detail what is breast cancer. You have ensured that people are not going by the myths. You have explained or opened up various ideas, various thoughts in young women. And they should not look at breast cancer in the negative manner. And there is huge amount of potential of life after cancer. It was wonderful talking to you. Thank you for being a guest. Like I mentioned, you were our 10th guest. It was wonderful talking to you. Thank you so much.
Thank you for the opportunity. Pleasure is all mine. Thank you so much.
Thank you.
To stay informed about the startup ecosystem, subscribe to my Startup TV.